So hello everyone and welcome to the 21st case of the case discussion series, and today we'll be discussing a case of MR fistulogram. So we have a 24-year-old male who came with perianal discharge since the past 1 month, and this is the MRI fistulogram done for this patient. This is non-contrast MR fistulogram. These are the stir axial images where we can see that fistulous tract, hyperintense fistulous tract in the 6 o'clock position ending into the external sphincter. These are the SAG images, stir, where again we can see this fistulous tract, dilated fistulous tract extending from the perianal region to the external sphincter. These are the coronal images where we can see that this tract is seen in the intersphincteric plane. This is the tract that is seen in the intersphincteric plane. This is the report that I had given, that there was a linear tract in the intersphincteric plane of approximately 2.7 mm length and 4.7 mm in caliber, which was seen from the left perianal opening extending anteriorly and opening into the external sphincter region at 6 o'clock position. There was no ramification or branching of the tract that was seen. Fluid is seen in the tract with no evident abscess formation. It is very important to mention whether there is any ramification or any abscess cavity formation that is present, because it is included in the St. James classification. There was no involvement of the levator ani muscle that was seen. The features were suggestive of a simple linear intersphincteric perianal fistula, which was grade 1 of St. James classification. We'll come to what is St. James classification first. But first we'll discuss the conventional Parkes classification by the surgeons. So the course of the fistula and its relation to the anal sphincters is described in the coronal plane on the MRI, and there are four major types: intersphincteric, transsphincteric, suprasphincteric and extrasphincteric. The superficial or submucosal fistula is also present, which is type A in this particular case, which does not cross any sphincter. That is a rare entity. So these are the four major types. Of them, intersphincteric fistula is the most common type, which was in this particular case as well. So the intersphincteric fistula, which is the type B here, we can see that the fistulous tract actually reaches the intersphincteric space, that is the space between the internal sphincter and the external sphincter, and then reaches the perianal region. The fistula crosses the intersphincteric space and does not cross the external sphincter here. Transsphincteric actually is the type C here, where we can see the fistulous tract actually courses through the external sphincter as well and reaches the ischiorectal fossa. Suprasphincteric fistula passes superiorly into the intersphincteric space and over the top of the puborectalis muscle and descending through the iliococcygeus muscle into the ischiorectal fossa. The type D here, where we can see that fistulous tract is going up and then coming back down into the ischiorectal fossa above the puborectalis muscle. The extrasphincteric fistula, which is the type E here, this is the extrasphincteric fistula, that crosses the perianal skin through the ischiorectal fossa and the levator ani muscle complex into the rectum directly. So it has no relation with the sphincters. So these are the type of fistulas according to the Parkes classification, and these are the types which are given by St. James University Hospital classification. This is the one that we use in radiology, where there are 5 grades. Grade 1 is simple linear intersphincteric fistula, where there is no ramification or abscess formation. Type 2 is intersphincteric with abscess or secondary tract. So here we can see one abscess, or even if there is some branching, it is given grade 2. Grade 3 is transsphincteric fistula, that is coursing through the external sphincter. Type grade 4 is actually transsphincteric with abscess or any secondary ramification. And grade 5 is supralevator or translevator extension, where there is no sphincter involvement. So this is another case of MR fistulogram that I came across, where a 35-year-old male came with pus discharge on the left perineal regions the past 6 months with intermittent pain, and this is the MRI picture, T2 weighted images, axial section, where we can see there is a thick tract with fluid within it, extending from the left perineal region, crossing the sphincters and reaching the anal region. These are the stir images, where again we can see that there is surrounding edema. These are the coronal images, T2 weighted images. There is no ramification or abscess that is seen, and the tract is seen through the sphincter. These are SAG images, where again we can see this dilated tract. These are the T1 post contrast images, axial section, where we can see that there is enhancement of the tract. Coronal images, enhancement of the tract and surrounding inflammation is seen. And this is the report that I had given, that there was a curvilinear enhancing tract which was piercing through both the layers of the sphincter complex, and it was taking a downward course through the ischiorectal and ischioanal fossae before reaching the left perianal skin at 5 o'clock position, and there was no ramification that was seen. Fluid was seen within the tract with edema and smudging of the left ischiorectal and ischioanal fat planes around the tract on stir as well as T2 weighted images, with mild post-contrast enhancement around the tract. There was no evident abscess formation that was seen. No involvement of the levator ani muscle was seen, and it was suggestive of a grade 3 St. James classification transsphincteric perianal fistula.